Thank you. Well, I hope I can live up to that promise. I must, first of all, when you say about the 18 minutes, I have an apology to make. I moved house on Friday, and in the interest of not very good resilience planning, I have no idea which box I packed my watch in. I have asked if I can have kind of a 5-minute warning if I look like I'm going over. Antimicrobial resistance, what is it, and why did I decide it was worth talking about it today? Partly, I'll be completely honest, when Ken asked me to present today, I said, I've actually got a presentation ready, could I give that one? But I thought it would be really interesting to give it to this audience because it's a new area for us at RUSI that we've been looking at. We've been working very closely with the Department of Health and also with the World Health Organization and the HPA on this. It's part of a series of work that we're doing with the Science and Technologies Facilities Council, future scoping and horizon scanning potential new security and resilience risks. And this is antimicrobial resistance, as those of you who work in the health service will be aware, is a problem for the health service at the moment. It's an increasing problem worldwide. And it's one that the World Health Organization think potentially could start to appear on risk registers in its own right in the next few years, as opposed to something that affects other risks on risk registers at the moment. So this is why I thought I would use the opportunity to give an introduction, show what's being done. But also, one of the things that's very interesting for us is seeing knowledge transfer between different parts of both the healthcare sector and of the security and resilience sector, and how they can work together on this, and how some of that knowledge transfer actually has benefits to other issues that can be dealt with and perhaps be addressed in the same way. So first of all, and apologies for those of you who are from the health sector who don't need the kind of Room 101 guide to antimicrobial resistance. In terms of what is it? It's the resistance of microorganisms, including bacteria and viruses, to medicines that have previously been used to treat them. The one that most people are probably aware of is drug-resistant tuberculosis, a disease that was virtually eradicated in the UK, is starting to be reintroduced, strains are being reintroduced that can't be treated with drugs that used to actually treat it quite effectively. And this is a growing problem. Hospital infections such as MRSA is an existence of antimicrobial resistance. There are also problems with other, both hospital-acquired infections and diseases that are coming in from around the world, becoming increasing issues in the UK. And this has a real potential to change the way, not only that we prescribe medicines that we've prescribed quite freely in the past, but actually potentially the way that we need to organise healthcare on a much more fundamental level. To give you a little bit of a background, and I will again, I'll make an apology before the next two slides. They were given in a presentation to RUSI a couple of weeks ago by Professor Neil Woodford of the HPA, and I had asked his permission to reuse them. I haven't heard back from him, largely because I've been on leave moving house, so I'm assuming he said yes. He may not, in which case I would apologise to him further. But just again, to give a bit of historical background, antimicrobial resistance, it isn't a new problem. It's actually been around for thousands of years, as long as there have been microbes around, whether they're bacteria or viruses. There have been ones that have been resistant to certain strains. There is archaeological evidence from 30,000 years ago of some of the resistant strains we see today. You can find in tissue from woolly mammoths, from creatures that have been frozen in the Ice Age. And we can see that it was a problem then. It's part of evolution. This is very much of interest to me. My academic background is in biological anthropology, a lot of which was evolutionary genetics. But if you see from the first diagram, you've got a load of bacteria and you treat them with antibiotics. There is one bacteria in that which is resistant to the antibiotics. All the others are killed. The one that's left expands to fill the gap. So what you end up with is the ones that were susceptible to medicine have been killed off, and you've got a new population of ones that are no longer susceptible to the medicine. And so the more you use antibiotics, the more you drive antimicrobial resistance and antibiotic resistance. It's a Darwinian response to evolution. And this is one of the big problems, that over the last 50, 60 years, we've been able to prescribe antibiotics very freely. If there's a suspicion, you've got an infection, try antibiotics and see if it goes away. And we're moving into a situation where that's not quite as possible anymore as it was. It may be that some diseases can't be treated by antibiotics. We have to be much more careful about the antibiotics we use. We have to be much smarter about the way that they're actually administered.
And one of the things, again, that we came across when we were looking at the history of this is if you look at particular diseases and particular antibiotics that have been used to use them, again, going back to TB, which is the one that most people are aware of, streptomycin, which was one of the first antibiotics that was effective against tuberculosis, actually started to develop resistance during the clinical trials for the introduction of that drug. So when resistance develops, it develops very, very quickly. And this has an added problem because in terms of the drug companies putting research into the development of new antibiotics, there's very little incentive for them to do so because they're going to develop something that in 2 years' time is not going to be much use anymore. And therefore, from their point of view, it's much more cost effective for them to put the money into developing drugs that are going to be useful 20, 30, 40 years. They get much bigger profit return. So one question would be, if there's research that needs to be done, but isn't likely to be done by the private sector because there isn't sufficient profit for them in it, is that something we should perhaps look at a more publicly minded, public sector funding to ensure that that research gets done? And that's one of the kind of questions that we're going to be exploring with Science and Technology Facilities Council over these series of workshops. Another thing that we looked at was the knowledge sharing about this. Again, if you use TB as an example, extremely drug-resistant TB, which is the most resistant type of the strains, is becoming a problem worldwide. This is by the end of 2001, at least one of the countries in red had reported cases of multi-drug resistant TB. You might notice countries that are white are generally the least developed, poorer countries. Question to ask is, have they actually not got the cases, or is actually their health surveillance not good enough that they've picked them up? And therefore, is the problem bigger than we're aware of? And should we be, again, looking at the way that we strengthen worldwide their recording mechanisms, the way that we share information, both with them and we help them to record so that there's better international understanding of what's going on? Don't expect you to be able to read this. Hope you recognise it as the National Risk Register. There are particular things on the National Risk Register already that drug resistance is a problem for. Pandemic influenza is perhaps the obvious one. Again, zoonotic and non-zoonotic animal diseases, things like Dutch elm disease, which has been in the news, is another health of plant populations we haven't really looked at, but that's something to come on. On the terrorist threat side, obviously the bioterrorism attacks in the CBRN world is a big issue. If you were going to do a bioterrorism attack, it would obviously be much more effective if you did it with a strain that you knew wasn't going to be susceptible to the drugs that are generally kept within the NHS. Certainly, whether you have issues with diseases such as anthrax, it's actually very difficult in countries such as India, where anthrax is fairly endemic, to be able to tell whether an anthrax outbreak is malicious or whether it's just a naturally occurring event. How do you actually start to differentiate between the way that you record and the way that you pick up those incidents to be able to tell what you're actually dealing with? And what happens if, when you do have a new emerging disease, such as a pandemic, it's one that's resistant to the drugs that you have stockpiled? Does that mean that actually there's an opportunity to stop looking at stockpiling and looking at how you would manufacture much more quickly when you've actually got the emergence of the disease? So one of the things that we started looking at was AMR in terms of what I would call traditional security risks, the things that we would think of as being already on the National Risk Register. And the kind of things it affects is, again, sort of in the normal security world, things like border and immigration policy. And as, again, some of you may be aware that at the moment, the policy, particularly for tuberculosis screening, is that it has been happening largely in country when passengers arrive at Gatwick and Heathrow, they're x-rayed, they're tested for tuberculosis there, and if they have it, it's picked up. The policy is now moving far more towards screening in country before passengers depart. One of the problems with that is it can actually take 3 months sometimes for the test to come back. So if you're pre-departure screening, you've then got 3 months at which they didn't have it when they took the test, but they may develop it in the 3 months. The World Health Organization is now funding research into a diagnostic test that can give a result in 100 minutes. Obviously much more impressive and much more effective. But you also have concerns such as the screening at the moment that goes on at Heathrow and Gatwick really only goes on at Heathrow and Gatwick. So if you think you may have a disease that may stop you getting into country, you may try and enter through another port that doesn't screen. It's also 50 to 100 times more expensive to screen at the border than it is to actually let that passenger in and treat them in the NHS when that disease is picked up. But you then have the added complication of during that period they've been in the UK, have they passed it on to anybody else? So is the NHS not just treating one person, is it treating a number of people? Now again, at the moment the numbers appear to be, even if they'd passed it on, usually about maximum between 1 and 3 times cheaper to treat everybody than it is to screen them at the border. But that has real political implications as to how you look at those issues of policy. It's becoming a real problem for repatriation of injured troops to the UK. Quite a lot, I go back to the map, which I'm not going to, the red zones. A lot of these resistant diseases are in countries where we have theatres of operations overseas. When we have troops, particularly who have blast trauma injuries, those injuries quite often get infected. They come back to the UK with some quite nasty infections. At the moment, the policy is that when they come back into the UK, they're moved to a hospital close to where their family are, so their family can visit. They're distributed around the country. But also what you're doing is you're distributing those nasty untreatable bugs around the country as well. Would it be more effective to quarantine them, for want of a better term, altogether in one area? But that, again, has very serious political implications. And again, serious for humanitarian aid in crises, particularly in Syria. You're bringing people back into the country with quite nasty diseases you don't really want to be spreading around. And when you start to look at these issues, you can start to have conversations that aren't just about antimicrobial resistance. They're about infectious diseases in general. And again, I mentioned before, there is a issue of bioterrorism attack, and there's an added danger of during pandemics, if the pandemic is a resistant strain. Although one thing that's been very interesting is that when we talk about smarter administration of antibiotics, smarter diagnosis of antibiotics for the right antibiotic for the right disease, during pandemic flu, the misdiagnoses of conditions as being treatable by antibiotics, which most flus aren't, they're viral infections, actually went down because GPs who were aware that there was a viral infection going round were more aware that it was a viral infection, their patients were more aware that antibiotics wouldn't work, and so we actually saw a decrease in misdiagnosis and misprescription of antibiotics during the flu epidemic, when you may have expected to see an increase. So if we look at the new resilience issues that may come from this, there is a real issue that we may be facing a change in healthcare provision, and that's largely in terms of diseases that we are, or conditions that we are used to be able to treat very easily, that we are used to be able to, we expect to recover from. We expect surgery to be very simple and not be particularly dangerous. That may change quite significantly in the future. And tying into that very much is this thing that Phil said about the move back into the home care environment. It's actually very good for antimicrobial resistance, or for tackling that antimicrobial resistance, to not have patients in a hospital setting. Hospitals are full of very sick people with lots of bugs around. If you treat them in their own home, they're less likely to catch nasty bugs from somebody else in the hospital who's got them. So it's actually a very good move in terms of challenging antimicrobial resistance to move healthcare, when it can be, out of the hospital into the home care. But that has other issues for the wider security and resilience planning that ties into things that Phil mentioned. A big issue is with cancer treatment. One of the cancer treatment, particularly chemotherapy, lowers patients' immune system. If they have a lowered immune system, they're more likely to pick up an infection. At the moment, a lot of cancer patients are given antibiotics prophylactically in case they get an infection, so that the infection doesn't take hold when they do. That drives antimicrobial resistance because you're overusing antibiotics. So again, one thing that may happen is that cancer treatment may become much more dangerous. You may have much less likelihood of surviving cancer, not because you wouldn't survive the cancer, but you wouldn't survive the infection that you picked up after the cancer when your immune system's down. One thing that we're looking at, again through the STFC, is funding into nanotechnology research, where nanotechnology targets specifically the cancer cells and kills the cancer cells, but doesn't damage the patient's immune system. That's not actually something that antimicrobial resistance specifically is looking at, but actually it has a really big impact on it. So getting the antimicrobial resistance people to talk to the nanotechnology people is a knowledge transfer that actually benefits both sides. Again, caesarean sections, that's something that at the moment we have a much higher rate of caesareans in the UK that's actually needed. It's something the World Health Organization is particularly always pressing the NHS to look at ways to bring down the rate of caesarean sections. It's very easy, it's reasonably safe at the moment to do a caesarean. If we were moving into a situation where you're much more likely to get an infection after surgery and you can't treat that infection with antibiotics, we may need to reassess our risk acceptance of where it becomes so risky during labour that you actually have to give a caesarean, rather than actually you've got a mother who's too posh to push and quite likes one. And again, similarly with elective and cosmetic surgery, there are always going to be situations where you have to have it. You know, there are a few caesareans that are going to happen. Elective and cosmetic surgery, nobody really needs a nose job, no matter how ugly their nose is. And it's going to have real problems with life expectancy. We may get back into a situation where we can't all expect to live into our 70s or 80s anymore. People dying in early childhood, in their 20s and 30s, of routine infections may actually become something that's much more common again if we don't actually look at protecting particularly the antibiotics that we have for future generations. And this again has issues with the distribution of patients. Do we need to look at actually restructuring the NHS and restructuring where patients are treated in a way that actually makes it less likely for these kind of infections to spread more easily, so they're very contained and you don't distribute patients around the country distributing the diseases with them, and do you actually keep them contained when you know you've got patients who've got them? Just to give you a little bit of an idea of the scale of the threat, there are 450,000 cases of multi-drug resistant TB annually, of which about a third die. And that's actually quite a big rate for any disease. But there's 150,000 deaths a year from multi-drug resistant TB. And that's worldwide. I would put, Phil, correct me on that if I'm wrong, I'm fairly sure that's worldwide. I should have made a note of it. Hospital-acquired infections, things like MRSA, there are 37,000 in the EU each year, and that's deaths from hospital-acquired infections, and that's similar to the number of deaths from car crashes. Now, it's quite putting it in that kind of context, and I think, well, not that many people die in car crashes, but if you look at how aware people are of the dangers of driving on the road, there's, I think, that less risk or less awareness of the risk with the misuse of antibiotics. What we're also seeing now is a link with the use of antibiotics in early childhood is being linked with childhood obesity. It actually, small children have disease, we give them antibiotics, that actually changes their gut bacteria, makes the way they digest food, and there are starting to be studies that are looking at, is that a link which actually with childhood obesity, with then obesity into later life, which has through life health impacts. A few figures on the cost of it. I'll go into the one with neonatal care in a bit more on the slide. So what's being done? Transatlantic Task Force on Antimicrobial Resistance. Personally, I think they sound like one of the world's most boring superhero teams, but it's a good name. One of the things that I was looking at is bringing down the inappropriate use of antibiotics. They estimate that 50% of use of antibiotics in hospital is inappropriate or unnecessary. We just use them because it's easy and we're used to doing it, and we really, really need to reassess how that's being done. That's being taken up by the EU Action Plan 2011. It's also one of the key actions there is bringing down the inappropriate use. And for about the last, I think since 2008, there's been a national European Antibiotics Awareness Day in November, which was 2 weeks ago. And some of the work we've been doing around this is tying into the awareness raising work that European Antibiotics Awareness Day does. In January next year, we have a new UK 5-year antimicrobial strategy and action plan, which is, again, bringing the TAPFA work and the EU action plan into a UK setting. We've got new border policy towards pre-departure screening, looking at taking that screening out into the countries. And coming back to neonatal care, one thing I've been finding really interesting is the National Institute of Clinical Excellence guidance on antibiotics in neonatal care. Because if TAPFA estimate that 50% in hospital is inappropriate, in neonatal care, only 5% of newborn babies who are treated with antibiotics actually subsequently have an infection. So you've got 95% of overuse of antibiotics. Now, what the NICE guidance has done, which is very good, is they've not only said we need to do something about this, they've set out very practical guidelines as to what you should do. And one thing they've done is they've split down the situations at the moment that would trigger antibiotic use into a series of red flags and non-red flags. And of 31 conditions, they've made 8 red flags and the other 23 non-red flags. Of the 23 non-red flags, you don't administer antibiotics anymore now, or their guidance is you don't administer antibiotics, you wait and see what develops. But that actually involves quite a lot of change in behaviour and change in risk appetite of the healthcare professionals. How willing are you going to be to take the risk that you've actually missed that one newborn baby who did have an infection that you would have administered antibiotics for, but now you're being asked to hold on. So again, one of the things we're going to be looking at with the STFC is how do you help to build that confidence building to make healthcare professionals more sure that they actually can withhold in this situation, to be prepared to withhold. So what's being done? So one of the things is raising awareness. We had some very good conversations with the World Health Organization where they were quite pleased that RUSI was getting interested in this, because they said they saw us as a key influencer of the security and resilience sector in the UK. So if we can get the message out that this isn't just a hard security issue, it's actually a resilience issue as well. And it's something that we all need to be thinking about. Appropriate use in hospitals is actually being quite largely addressed, and there are things like there's the NICE guidance, most of the hospitals are aware. MRSA rates, particularly in the UK, have come down significantly in previous years. What is still a problem, particularly with GPs, is patients go in, they've taken a day off with a cough, they expect to be given something, the GP says to them, it's probably a viral infection, antibiotics aren't going to work. They say, I don't care, I'll give the antibiotics a go anyway. The GP's got a limited amount of time, he wants to get them out and get the next patient in, he gives them the antibiotics and they go away. The antibiotics don't work, pushes up antimicrobial resistance, and actually we have to find a way of getting this message out both to the patients as well as the healthcare sector that this isn't going to make a difference. That knowledge transfer is really important. So looking at nanotechnology, one research project we came across, really interesting, one of the places that MRSA bugs live in hospitals is in the seams of hospital gowns. Peninsula Medical School at Exeter University is working with the fashion students at Falmouth University to create seamless hospital gowns, nowhere for the MRSA to live. Great project, really great knowledge transfer. You wouldn't necessarily expect healthcare resilience professionals to be working with fashion students. Had a really positive outcome. That's the kind of thing that we're trying to look for and to bring together. Are there, other issues? Is this something else that could be used to help other sort of pandemic planning, bioterrorism planning? And social media and distancing, as Phil was saying, use of, again, of moving healthcare into home, of using telemedicine. Yes, it stops infectious people coming in contact with other infectious people, but there are wider resilience issues of what happens if that connection goes down. As mentioned, workshop 6th of February. It'll be on our website. I won't go into detail because I'm running out of time. If you'd like to come, please let me know. The kind of things that we're looking at, certainly of getting the awareness out to the business continuity and emergency planning, is outbreak surveillance. So any kind of outbreak, if you've got good surveillance, you can see where pockets are coming up. How are you sharing that information? Simple hygiene measures. The hygiene measures that are promoted for pandemic flu shouldn't just be for pandemic flu, they should be general. I apologise to people I've been coughing and sneezing on all today. I'm aware I'm doing it. It isn't part of the presentation. I generally just didn't bring enough tissues with me. But also the public awareness. The more people are aware of this, the more they'll actually do something about it. And also, certainly at this stage, in terms of risk registers, you may have pandemics and bioterror on there, but perhaps start thinking about antimicrobial resistance more generally. How can you embed these general practices that would actually help things across the board? These are probably just not particularly relevant in the time we've got. Again, just building confidence when to withhold antibiotics, standardise antibiotic regimes across the NHS. I'm going to go through these, but this is the important one, and this is from the President of the Infectious Diseases Society of America when they did a report a couple of years ago. The way we've managed our antibiotics for the past 70 years have failed. We have moral obligations to ensure they're available for future generations. And I think that's the really important one to get out. If we don't start changing the way that we prescribe and use antibiotics, we may not have them in 20 years' time. And that is going to have a massive impact on healthcare resilience across the board. And so I think part of what we're doing is trying to raise awareness of what isn't a resilience issue at the moment. If you address it now, it may never become one. If you don't address it now, we may be in a very different position in 10 years' time. Thank you.